We are actually 3 minutes past the time for this session. So those who would like to attend, may I please request if you would take seats so that we can start this session and end in time. So, Assalamu alaikum. I welcome you all to the palliative medicine session for today, which is the last session. I'm Atif Salim, one of the palliative care consultants at Shaukat Khanum Hospital in Peshawar. Without wasting any further time, I'm just going to brief you with some housekeeping rules. I would just request if you could keep your mobiles to silent. You're more than welcome to ask questions, but we'll keep it to the panel discussion in the end. And do not forget to fill the evaluation form at the end of session. We value your feedback. It is going to be an honor for me to introduce you to our chair of the session, Dr. Chris Parham. Please join me in welcoming him. He's with a great round of applause. So I'm very thankful to him for coming all the way from the UK for this session. The first talk is going to be by Dr. Chris Parham. It's going to be on communication skills training for the oncology professions. Over to Dr. Chris Parham.
Lovely. Can you hear me all right? It's wonderful to be here. Thank you for asking me. Yes, my name's Chris Farnham, and thank you for that kind introduction. So 20 minutes to talk to you about communication skills is quite short, but I wouldn't presume to teach you how to communicate, because I'm sure you all do that brilliantly anyway. But what I want to do today is to give you 3 kind of top tips, really. So if by the end of today, those have struck a chord with you, you can go away and read a little bit more about them. So there's just a couple of slides, really. There we go, it works. So we're going to cover 3 things. One is going to be a little bit about your voice. The second thing is going to be a little bit about something called 3 circles. And then we're going to talk about safe conversations. So I want to tell you a story, just a very short one. About 38 years ago, when I was deciding whether or not to be a doctor, my other option was to be an actor. The acting world, I suspect, was very pleased that I chose medicine, and medicine probably less so. But anyway, I went in and trained as a doctor. And then after I qualified as a postgraduate, I kind of thought, what had I missed out on? What had I not done? So in London, I went back to drama school and met some amazing people, some really fantastic actors from all over the world. But most importantly, the people that really affected me were the teachers. And they affected me because the methods that they were using were so completely different to the methods that we use within medicine and nursing. And I kind of wondered, well, you know, are these going to be applicable in any shape or form to us when we're training as doctors and nurses, but also when we're teaching others? And of course they can. So, for example, if we were to take, I don't know, a 21-year-old woman from here, from Lahore, and we take her to London, and we put her through 4, 5, 6 years worth of training in one of the good drama schools there. When she's finished that training, and you go to see her in a piece of classical theatre, so you see her playing in a Shakespeare play where she is playing Hamlet, Prince of Denmark. Okay. What you see on that stage is not a 24-year-old woman from Lahore. What you see is Hamlet. What she is doing is taking a really complex message, delivering it to her audience, and you absolutely believe that she's not that 24-year-old woman from Lahore, but you absolutely believe that she's the Prince of Denmark, and you understand what she's saying. So are we any different? The answer is no. So our audience might be slightly smaller than a huge, great big theatre. And our audience may just be the patient and their wife, their husband, their children, but they're still the audience. We're still taking a really complex message, we're delivering it to them, and we must make sure they believe us as the doctor or the nurse talking to them, but they also believe and understand the message that we're giving. So we're not so different. So let me take the first thing, which is voice. Can you all just stand up for a second? Sit down. Silly me. So you were great. You all did the right thing. Why did I make you do that? I suspect there were quite a large number of you that thought, oh, make him go away. Just shut up. I do not want to stand up. What's he going to make me do? So your pulse would have gone up. You'd have got a bit sweaty. If I'd had a plethysmograph, your kind of respiratory rate's probably gone up a bit. And then as we stood just quietly for a second, you started to feel a bit uneasy. What are we going to do? What are we going to do? And then that huge sense of relief when I said, sit down, it's like, oh, thank goodness. It's no different. So those emotions, in a silly way, are absolutely no different to the emotions we feel when we're going to go and give a big talk, when we're going to go in and tell that patient we really like that their PET scan shows they've got disease progression and they're going to die. And isn't that a strange word, die? I've spent the morning listening to some really, really clever people talking about some really fancy and expensive drugs. Actually, an awful lot of those patients today are going to die. And we haven't actually mentioned that word today. So welcome to the palliative care session. It's really interesting. We've got an hour and a half to talk about the last few days, weeks, and months of patients' lives. So this is really important, isn't it? So when we're going in to have that conversation, that really difficult conversation, we need to be like that 24-year-old woman from Lahore playing Hamlet. We need to be believable to our audience, which are our patients and their families, and they need to hear and understand everything we say. Now, if if I'm really nervous and my voice isn't great, what do you feel? So do you still believe me in the same way that you believe me when I'm standing up here feeling really confident and talking to you? Can you hear what I'm saying? No. So when my voice started to quaver and I was finding it difficult to get my breath, what do you start doing? You stop hearing the message and you start listening to my anxiety. Am I still as believable? No. So as actors, they spend weeks, months, and years really working on their breath, really considering how they're going to support that sentence, that really difficult sentence. So all the higher emotions that are influencing our respiratory rate, sweaty, pulse, that doesn't come through. We don't change. We're still believable. We're still taking on that complex message, and the audience is still hearing it. Okay, so voice. If you're interested in one thing, read up a little bit about voice. Okay, so as part of my journey in that story earlier, I hooked up with a woman called Patsy Rodenberg. She's the professor of voice at Guildhall School and the Royal Shakespeare Company. But she teaches everybody about their voice. And I asked if she wanted to come and help me train doctors and nurses. And thankfully for me, she said yes. So she and I are now going around and doing some of this work. But she has a thing called presence. And it's a word that's gained an awful lot of traction recently. So she would argue, and I'd agree with her, that we can't be successful. So politicians, sports people, doctors, nurses, we can't be successful in what we're aiming to achieve unless we're present with our patients. So what does that mean? Well, she uses a thing called 3 circles. 1, 2, and 3. So third circle, it's all out here. It's high energy. It's all about me talking to you. It's very princely. So the body language matches the volume and it matches the ability for me to feel quite confident. But the energy is flowing from me out to you. I'm not bothered in what you think. I'm not bothered in what I don't want to hear your opinion. And that's fine for the short time, but boy, is it tiring for the person doing it. And it's really tiring for you. And you just switch off. It's noise. So it's fine. If I'm at an arrest and I'm the medical registrar, okay, I want you to take the head. I want you to do the compressions. Can you go and get the drug trolley? You give me the history. I need to know come on, tell me I don't walk in there. Oh, hi, is everyone okay? You had a nice day. Ooh, someone's a bit poorly. That doesn't work. So you need to be in third circle. It's all about getting things done. But that's just in the moment. And you need to revert into second circle. We'll talk about that in just a second. So you've got third circle at one end. You've then got first circle at the other. First circle's kind of really quiet. And it's all about me. They're the kind of mood hoovers in the team. I don't know if any of you have got mood hoovers in your teams. I know I have. They're really hard to engage. So they just sit there really quietly. They don't really give an opinion. Come on, work with me. So the third circle are big and loud. Sometimes there's too much. First circle, absolutely polar opposite. You're trying to draw things out from them. And what you're aiming to do is to bring both of the first and third circle into you at second circle. And second circle is where there's a flow of energy, for want of a better word, back and forth. You're inviting that person to come to you and you want to hear what they say, but you're also enabling them to hear what you're saying. So how do you do that if you've got somebody who's in third circle? You're going to kill my mum. If you don't give her more treatment, she's going to die. It's all your fault, doctor. It's you. If you go into them in first circle, oh, I'm really sorry. They're not going to hear you. You're not going to be able to change what's happening. If you go to them with a brief third circle, okay, just stop a second. Okay, I can see you're really angry, but I can't answer any of your questions unless come and sit down with me. Come and have a sit. And then, now, what is it? Just tell me what it is you're so upset about. So you've brought them down from third circle, that high energy, all out there state, and you've brought them down to you in second circle. And you're saying to them, please, just tell me what it is, because I can only help you if I can hear what you're saying, but I can't do that. You're saying in a parenthesis in third circle. So these three circles are really important sometimes in trying to work out how you're going to match this energy. So we've talked about voice, the importance of voice and trying to sustain that voice. We've talked about being present and how you can really only be present in second circle. So you've got third circle all out there, first circle all in here, trying to be in second circle. So then how do we take all of this and translate it into more clinical practice? Well, it's what we call sort of safe conversations. Now, gosh, even now, I can still teach students how to do something like a paracentesis or a pleural drain. And the reason I can still do that is because, I was drilled and drilled and drilled and drilled into doing something. And all of you, I'm sure, have got various procedures that you either do or you teach. And there's a particular sort of standardization to all of these, because over the years, we've found that this is the best outcome for patients. If we do it like this, we get the best outcome for patients. So we get very used to doing these practical procedures in a particular way that leads to the best outcome for patients. So why do we not do this for conversations? And you may say, well, it's a conversation. Do you remember when that doctor came to speak to mum and he was so arrogant and the way he just told her that her cancer had got bad? Do you remember? Yeah, I do remember. And do you remember how mum just cried for hours afterwards and just gave up? And yeah, I remember. So when conversations go badly, they live on in the memories of our patients and their families. So long after they've died, those conversations live on in their memory. So I would argue that just as if we do a practical procedure badly, it has consequences for patients. If we have a conversation with our patients that goes badly, the consequences, again, are just as devastating, and sometimes they're longer lived than some of those physical complications. So why don't we prepare for those kind of conversations in a way that's just as safe as we would do as if we were doing a paracentesis? We don't, or rarely do we. So how do we do that? Well, part of it is making sure that we know what the conversation is that we're going in for. So very rarely do you turn up to a patient with a very large abdomen to do a paracentesis without knowing what you're going to do. So don't be any different to that with a conversation. When you're going to set up for the paracentesis, you know you're going to get a consent, you know you're going to lay out the trolley, you know how you're going to prep the abdomen, you're going to anesthetize it, you know how you're going to drain it, and you know how you're going to provide safe aftercare. Why is that any different for a conversation? So if we're going to go in and tell that patient that we really like with that great family, some really bad news that all that chemo that they've been through, all that radiotherapy, that surgery they had ages ago, none of that has worked and they're going to die. Why is that any different? So just as we know that every abdomen is different, and we know that if we prang something and there's blood when you're aspirating, you know what to do to make it safe. So we need to prep for when we're having that conversation, how that equally is going to be safe. Because we don't know how people are going to respond. You don't know what those kids have just been through this morning. You don't know what any of those people you're about to talk to, what's happened to them before they've come to see you in hospital. All sorts of things that could alter the way they react to you. But you need to be able to plan. So actors know how to do that. So I'll tell you a little, how are we doing time-wise? So we're 5 minutes, good. I'll tell you one little story. So a few years ago now, we took 30 actors and put them, 30 doctors, that was a slip, wasn't it? And put them through drama school for a year. And one of them will stick in my mind forever. So he was a consultant neurosurgeon from Queen's Square, near where I was working. And we tried to put people into systems that weren't medically based because they needed to understand about themselves and not return to type as a doctor. So bizarrely, we gave him a dry cleaners to run for an hour. There were 2 rules. One rule is you're not wrong. No, we're never, ever wrong in the dry cleaners. And 2, you give no money back to the customer. You could see this man rolling his eyes thinking, what, I'm a neurosurgeon. What am I doing running a dry cleaners for an hour? So he was sitting there. First person, I was going to say, first patient comes in, first man comes in, and he hands his ticket over and says to the neurosurgeon, 151. Tick, 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 tick. Out comes the shirt. It's not my shirt. 151, it's your shirt. I brought in a $500 white shirt this morning. That shirt is pink. I'm not going out in a pink shirt. I said, you are. I said, do you know who I am? He was a famous film producer. He said, I have got a film premiere tonight. I'm not going down the red carpet in a 500, he was swearing, pink $500 pink shirt. Anyway, 10 minutes later, he walked out of that dry cleaners with an apology and his $500 back. So we sat down with a neurosurgeon. He said, what were the 2 rules? Never apologize, don't give the money back. What were the 2 things you did? Gave him the money back and said, sorry. So what happens when you're doing an operation and something goes wrong? Well, it doesn't go wrong. I've never done anything wrong. Yeah, but it will go wrong. What happens? Because when things go wrong, you do the absolute thing we've told you not to do. Oh my goodness. I didn't even think about that. So when an actor goes on stage and they open a door and the princess of something is supposed to be behind that door and there's nobody there, 1,000 people in the audience that have paid $200 a ticket to see you, you can't go, oh, sorry, she's supposed to be there. You have to make it work. You have to have a plan B. They want to see the story unravel. They want to hear the message. You want to be believable. So with this neurosurgeon, probably one of the best lessons that he learned was that when things go wrong, he did bad things. And we had to really work hard with him to get him back on track. So he began to think about what his plan B was, certainly intraoperatively. Okay, so the three things that I want you to take away today is, one, think about your voice, because it is so important. Think about those three circles, about the third circle, first circle, and how you can try and stay in second circle with your patients and their families and your colleagues. And then think about how you can plan to have safe conversations. What I'll give you just before I finish is there are three little things here. There's a bit of a QR code. There's a film that we made recently about caring with compassion, which is about communication. But we now have that every single member of our staff. It's about 22,000 people, so I have to watch that. It's quite emotional, just to warn you. Patsy Rodenberg, there's her TED talk. It's on the second circle, and it's a 6-minute talk. If you don't understand presence, you will do after that. And then she and I have done we've done some Spotify podcasts, and that's our little podcast at the bottom, which is called Craft, Sweat and Joy. So Patsy talks to various actors and then talks to me for a bit. But this is about the craft of medicine. And you can't learn everything just going on a course like today. It's something that we have to keep going on and on and on about. So 3 things: voice, 3 circles, and then safe conversations, and then some little bits just to follow that up with. Thank you very much.
So we are going to move to the next presentation. One thing I remembered, people will forget what you said. People will forget what you did, but people will never forget how you made them feel. So remember this. This is very important. I'm going to move to the next talk of today, and that's going to be by Prof. Ian Laurie, and it's going to be on taking palliative care to the doorstep. Over to Prof. Ian Laurie.
Good afternoon, everyone. My name is Ian Laurie. I'm a consultant in palliative medicine in Manchester in the UK. It's currently between 10 and 12 degrees here, and I think it's near 30 where you are. So it's a real shame that I can't be with you for this year's conference. I've been asked to talk about palliative care, taking palliative care to the doorstep. And this fits in hopefully quite well with this afternoon's programme. Chris talking about communication skills, which is a key part of palliative care in medicine. And then you've got Harun and Mohammed talking after me about the home care service. And finally, and I think it'll be a very interesting talk, is why I chose palliative care from Aisha. So all in all, quite a good programme for this session. So thank you for inviting me back. I was over in Lahore in May, and as you can see, I got locked in Lahore Fort by these 2 kind guards, but they did let me back out again. What I'm going to talk about this afternoon is defining palliative care and what is good care. We have to then think about bringing it home to Pakistan and what are the specific plus points and barriers in the country. What are the components of home palliative care services? And how in Pakistan do we progress this? We've got to think, as I mentioned, of barriers and limitations, because if you don't consider them, there's no way to mitigate against them. And finally, we've got to think about what our aspirations are. The famous phrase, Rome wasn't built in a day, is true of any service developed, and it's to think about, yes, where do we want to be in 1 year, 5 years, 10 years time, but also what is achievable now in small steps. So let's think about palliative care. I have looked over the years for new or updated definitions of palliative care, but I still like the World Health Organization's definition because it describes palliative care as an approach. So it's not a recipe. Okay, there's no set procedures involved, but it focuses on quality of life. And it's not only of the patients, but it's those close to them as well, whether they be relatives or friends. Yes, it's about considering the suffering, but we have to think of all aspects of suffering the patient who is receiving palliative care or might experience. Finally, it's the active total care of patients. Palliative care is not giving up. It's not, there is nothing more we can do. And it's definitely not passive. So people who aren't going to be able to be cured of their illness, and it's their active care. Moving on from that, what contributes to good care, it's thinking about that suffering, thinking about your treatment and your management, and deciding what contributes to good care. It's everything. If you just address the physical needs of the patient, you will not succeed in managing their to improve their quality of life. We've got to think of the social aspects of their lives, their psychological status, and those around them, and quite often their spiritual needs as well. So this has been all put together into a total pain model by Dame Cicely Saunders. And so I do urge everyone to not just think of the physical. Progress in Pakistan. In 2003, the Council of Europe designated palliative care as an essential and basic service. And for many years, this is where I give a huge shout out to my friend Haroon for working so tirelessly in Pakistan with his colleagues to achieve recognition of palliative care medicine as a specific specialty. And then in 2024, in May, when I came across to Lahore, we had the first FCPS to final exit clinical examination in palliative care. And you can see the pictures there, my station, station 3. The candidate was excellent, and it was really a groundbreaking moment to have that first clinical exit examination in Pakistan. So thinking of the country itself, Pakistan obviously is a developing multi-ethnic country with a huge population of 245 million or more. But in the next 25 years or so, it's expected or estimated that the population will rise to 368 million. So you're dealing with a bigger population, you're going to be dealing with more people who are unwell. And the leading cause of death in Pakistan is ischemic heart disease, but that can fall under the remit of palliative care as well. In terms of malignancies, you can see breast, oral cavity, colorectal, esophagus, and liver there. But I think we've got to be careful not to think of palliative care as just cancer. It can be a lot of the other failures, heart failure, liver failure, kidney failure. It can be some of the neurological diseases as well. So there's lots and lots to it, as well as things like chronic obstructive airway disease. But what we do know is across the world, there's over 40 million people who need palliative care. Excuse me. And the majority of them are aged over 60. And again, the vast proportion of them are from low and middle income countries. So you already see one of the issues we have, that the people that need palliative care are often not in the best places to receive palliative care. Again, over the next 35 years or so, almost half of all deaths each year will die with health-related suffering. And health-related suffering obviously can take many forms. But yet again, over 4/5 of these people will be in low and middle income countries. So, as we've alluded to there, there's little or no access to palliative care in just under half of countries. And even in the remainder, it's very patchy and uneven, with middle and low income countries faring worse. So an estimated 20 million people have unmet palliative care needs. And out of 234 countries, only 20 have achieved the level of integration of palliative care that we would class as good into the mainstream healthcare services in those countries. So we've got a picture of need, lots of need out there in terms of palliative care, but the provision isn't there in the middle and low income countries that there should be. So what palliative care is not is an indication of failure. It doesn't mean anybody's done anything wrong. It's just a stage of someone's illness. It's not the last gasp. It's not the last days of life. It's not terminal care. In the UK and a lot of parts of the world, we would reckon that someone was in the last year of their life, they would be palliative. So end of life can be the last year of life. I suppose the question is, you should ask yourself, would I be surprised if this person was to die within the next year? And if the answer to that question is no, then they would be palliative. Palliative care is not a hospice or a specialist unit, a specialist ward, and it's not always provided by doctors, nurses, and other healthcare professionals. It can be provided by a wide range of people. And this is us getting to the point of taking palliative care to the doorstep. Palliative care has changed over the years. The traditional model was that someone would have a diagnosis, all efforts would be at curative care, but when it was recognised that the patient was starting to die and approach the end of their life, they would swap to palliative care. It was a cut-off like that. Whereas the revised model, palliative care can be involved throughout the patient's journey. So sometimes during screening, if people have symptoms, at diagnosis, even if curative care is going to be offered, they may have symptoms, issues, and other areas of suffering that palliative care can help. But as you can see from the diagram, the yellow triangle there, as the options for cure decrease, the opportunities to provide more palliative care increase. Obviously, at the end of life, there is a big role for palliative care, but also into bereavement. It shows you how our thinking has changed, and oncologists and palliative care specialists work even more closely than they ever did before. So developing care at home, taking palliative care to the doorstep, and what do we mean by home? We mean everywhere other than hospital. So in the UK, that could be hospice, it could be a nursing home, a care home, the patient's own home. And in Pakistan, that probably does mean the patient's own home. But the principles of palliative care at home are exactly the same as those in the hospital. The same approach to physical, social, psychological, and spiritual issues and suffering is exactly the same. But it needs a public health approach. There needs to be integration into existing health services and systems, and it has to be in policies that palliative care should be included in these provisions. What we should be thinking of, and I kind of mentioned this at the beginning, is that the system should be realistic and sustainable. Where we want to be in 10 years' time, we won't be able to achieve in the next 6 months. The goals and that's setting up a home care service, and you'll probably hear more about this from Mohammed and Haroon, should be very realistic. What have we got to provide at the moment? What facilities have we got? What money have we got? What staff do we have? And what's the need that's out there? And it's probably starting on a small scale, possibly with a small specific group of patients, maybe a disease group or a geographical area, whatever, so that you can set up developing that service and monitor what goes well, but what also goes less well. We've got to think, and this is, I think, especially true in Pakistan, is we've got to recognise the local resources, beliefs and customs. In the UK, we describe a lot of the population living in nuclear families with maybe relatives and other family members living at a distance. Somewhere like Pakistan, it may be the exact opposite, that families are living much closer together, and their lives are very intertwined, and there's a support system there. So we've got to think about our non-professional carers who are going to be caring at home. We've got to think about what's out there in the community already, and it might not be setting up a clinic, hospital. It might be setting it up in a faith centre or a local unused shop, a school or something like that, to take palliative care to the patient and closer to them. We've got to think about people's beliefs as well, and their attitudes towards illness, disability, dying and death, because that is very much part of palliative care, and should be given recognition. And I think, especially in the UK, that's not always the case. I mentioned there about informal carers using volunteers, etc., is a good way of providing a service, and these volunteers can be trained where you don't have enough of the palliative care profession. And some studies have said that developing care at home, taking it to the doorstep, may save money. I think there's probably not enough work being done on that yet. But it does save hospital admissions, etc. So that's evidence for the future, hopefully. So the components of the service, and I kind of mentioned this, that if palliative care at home is going to succeed, the relatives are just as important as the palliative care professionals helping provide their care. So yeah, we have nurses, doctors, maybe physiotherapists, etc., speech and language, dietitians, etc. But we have volunteers as well. We use a lot of volunteers in hospices in the UK, but for developing a service at home in Pakistan, it may be that you look at training some volunteers in certain aspects of providing care to your patients. So I think we've got to be realistic overall. What fits our country, our culture, our social norms? Because there is no point in trying to provide, for example, a Western style palliative care system when we've got not long distances between places. We've got a lot of towns and cities, we've got National Health Service, etc. There's no point in transplanting that to Pakistan because it won't work. Pakistani people have their own culture, their own social norms, and the system should fit in with that. And I've said it 2 or 3 times now, what is possible and what's not possible. Don't set yourself up to fail. Start small, evaluate as you go along, and the service can develop. And then coming back to it again, how do we harness the huge power that communities and families have? in helping support palliative care patients? And how would that look in Pakistan? So barriers, we've got to consider the barriers. There's lack of access and opportunity for education about palliative care in Pakistan. That should improve now that the specialty has been recognised, but there's not the same volume of online courses, study days, conferences, etc., that there are in other parts of the world, and also lack of funding and support to attend educational events. Medications, in May I was talking to Iranian colleagues about this. Obviously, and this is worldwide, people can have a fear of both taking opioid medication or prescribing opioid medication, although these are largely unfounded if it's done properly. Obviously, there are regulatory restrictions, so being able to get modified release morphine in Pakistan, but not being able to get the immediate release is a barrier to good symptom control. And also insufficient funding for healthcare overall. People in different specialties, people with different needs will all be vying for some funding for their condition or specialty. And palliative care will have to be shouting with the rest of them. There can be perceptions both amongst healthcare professionals and the public that there's a reluctance to discuss death, and that palliative care is all about death. Palliative care is not all about death. Some patients can live for many years with a good quality of life. Some don't, but it's not all about death. And there's good evidence that people actually want to discuss their illnesses and the end of their lives. And that can help them. And doing that in their own home with people they trust can be a really good way to settle any psychological or spiritual suffering. And I come back to culture, society and faith, etc. influences. There can be, and this is not specific to Pakistan, that we never give up in life. Life matters at any cost. Sometimes there can be an unrealistic hope of cure. And we've got to actually, instead of fighting against those beliefs, we have to work with those beliefs. And again, getting out into the community, into people's homes, etc., is a really good way to do that. What's driven success elsewhere? There's some evidence from a few different developing countries that the strong family culture, as we've mentioned, has proved to be really helpful in achieving success with home care services. Putting things into the community rather than centering them on a hospital makes a big difference. And where local health services, but also government approaches to health have been integrated, there is more success in providing palliative care. I hinted at utilising existing resources, buildings and people, rather than trying to build a shiny new hospice specifically for palliative care. We've talked about volunteers, there could be family, laymen, women, and professional volunteers that are trained. Thinking about reducing prescribing, it's not all about drugs. If we're looking at the social, the psychological, and spiritual as well, it's not all about providing medications. So we don't want to over-medicalise. And finally, we have to advocate for palliative care, both as a specialty and as an essential part of all healthcare. Thank you very much for listening.
So, sorry, from voices, three circles, safe conversations, to recognizing the barriers that we have in our country, especially the culture, the norms, the beliefs. So now we are going to move to the East And I'm going to now invite Dr. Atif Fakar for his talk. Thank you.
Bismillah ar-Rahman ar-Rahim and Assalamu alaikum, everyone. So let me start off by a question, a very simple question that I'd like to ask all of you. If I were to tell you that you've only got one day left to live, that you're going to die tomorrow, where do you want to die? Would you prefer to die at home in a comfortable and familiar environment, surrounded by loved ones, family members? Or would you prefer to die in an unfamiliar, strange environment like the hospital, surrounded by strangers like doctors and nurses that you don't know? What would be your reply to that question? Oh, right. So most, if not all of you, will prefer to die at home. And I wish I could tell you that that's what happens all the time. But even in Pakistan, and especially in the urban cities in Pakistan, nothing could be further from the truth. As much as we would love for us and our loved ones to die at home, most deaths are still happening in institutional settings. They're still dying in the ICU. Our patients are still dying in the ER, on the ward, the worst possible place that someone could die. And that's a culture that we're hoping to change. And the whole focus of the talk today is going to be on home-based palliative care, particularly as it pertains to Pakistan. So just a slide on my disclosure, I've got no conflicts of interest and I've got no relevant financial relationships to disclose. Um, in the interest of time and to avoid duplication and redundancy, I'm going to focus specifically on Pakistan. Where do we stand in terms of how developed home-based palliative care services are? And I'm going to share a little bit about some models that we do have that exist in Pakistan, how they're working, share a little bit of our successes, and also share with you some of the challenges that we've encountered. So I'm going to skip over a few slides because Dr. Laurie has already covered that, but I will show these very important numbers with you. These are drawn directly from the GlobalCan that was published earlier this year. These are revised numbers. And what we are estimating now is that in Pakistan, every year, about 190,000 patients are diagnosed with cancer. And out of them, about 120,000 of these patients will die each year. So essentially, what we're saying is that a 70% age standardized mortality rate. Previously, this used to be 57%. So instead of getting better, it's only gotten worse. So 70% of these patients are going to die within the first year of their diagnosis of cancer. And all of these are patients that would benefit from palliative care services. These numbers that I'm sharing with you is directly from the Lancet Commission on Palliative Care and Pain Relief. And what they did was they conducted a need assessment in various countries, Pakistan being one of them. And they estimated that in Pakistan, it's estimated that about 900,000 patients each year are in dire need of palliative care. And out of those, no surprise, you can see that malignant neoplasm tops the list. The number is very close to what GlobalCan has estimated. 187,000 patients are diagnosed with cancer each year that require palliative care. But where do we stand in terms of how developed palliative care services are? And the numbers are very disappointing, very disheartening. So what they estimated was that for every 90 million of our population, there's probably just a single specialty palliative care service. So what I'm trying to say is less than 1% of our population has access to palliative care if they choose to receive it. So let's not talk about the West. Let's talk about the East. Let's talk about countries in the vicinity of Pakistan, countries that are most comparable to Pakistan, countries that fall in the Eastern Mediterranean region. So we're going to look at Iran, Egypt, and Saudi Arabia. And I'm going to share with you the community-based palliative care services, the home-based palliative care services, standalone hospices, and look at the number in conjunction to the population. So they've got more home-based palliative care services in Saudi Arabia and Egypt and Iran than we have in Pakistan. And look at their population and then compare that to our population. And again, these are very dated numbers. Our census, the one from 2023, now estimates that our population is 240 million. So we're lagging really behind. Having said that, it's not all bad news. Since the time that this report was actually published, there's been a lot of development in terms of home-based palliative care services. And I'm sharing with you a map right now. We've tried to map out where are these palliative care services based out of the home in Pakistan. And you can see all across Pakistan, starting from Karachi all the way up to Peshawar, we've now got home-based palliative care services that have developed. And I'm just going to list them over here for you, but no surprise, Shaukat Khanum, Lahore, Shaukat Khanum, Peshawar, Aga Khan University Hospital in Karachi, St. Elizabeth's home-based palliative care service in Hyderabad, Shifa International, all of these leading institutions recognizing the need for home-based palliative care services have established wings to provide palliative care at home. And I want to share a little bit of our journey at Aga Khan in Karachi, how we established our palliative care service. It's been a long journey. Didn't happen overnight. Started very, very humbly with just a single part-time doctor and two full-time nurses. That's all. Our whole team was 2.5 people. We started back in 2002, long before we had an inpatient palliative care service or clinics or a consultation service. But gradually over the years, our numbers have grown. Our team has grown as well. So from 2.5 people, Alhamdulillah, now we're up to 325 healthcare professionals that are providing home-based palliative care. We're now just in the last year, we conducted close to 93,000 home-based palliative visits in the calendar year of 2023. And you can imagine Karachi being the large metropolitan city that it is. The population of Karachi itself is 20 million. 20 million. So we're dealing with a metropolis, a very large city, and it's hard to provide palliative care services over there. So what we did was we followed the way that the government actually divided Karachi into districts, 7 districts, and we re-engineered our home care services to actually follow a hub and spoke model, where the hub actually is our main campus on Stadium Road in Karachi, and then we've developed these spokes in various districts in Karachi, where we're able to deploy the services to the patient's home so that they can receive the necessary palliative care at home. We do conduct MDT for our patients at home as well. We have a fortnightly program where we conduct the MDTs, the multidisciplinary review of the care plans for our patients. And in addition to that, we have transportation for our staff, and we're actually responsible for taking them to the patient's home and then bringing them safely back. And in addition to nursing, physician, rehabilitation services, these services often we're providing 24 hours around the clock. We're also providing durable medical equipment to the patients who require oxygen. Occasionally, some of our patients will require other medical equipment like an NG tube, a Foley catheter, and we're providing all of that for them at home. We're also delivering medications to their home so that they don't have to come to the pharmacy to pick up medications. We're also doing portable imaging, x-rays, chest, abdomen, wherever required, to figure out how we can best service our patients. We're doing continuous infusion. We've got infusion pumps that we're using for patients who've got intractable symptoms. And very recently, about 2 years ago, we also started catering to pediatric patients at home. In the past, we were not doing that because they require a higher acuity and higher level of care. And the expertise at that time we didn't have. Now we do. So just a snapshot of our core team in terms of the physicians. We've got faculty, fellows, and senior medical officers that are providing the care at home. And then we've got various cadres of nursing colleagues who are providing care. And we also have a dedicated wound care nurse at home. So this is a core team, and this is the extended team. The extended team doesn't actually make home visits, but what they do is they coordinate with us, they do teleconsultations, video consultations, and we ensure that there's seamless coordination of the plan of care for our patients. So just the last few slides that I wanted to share with you. Since we instituted the home-based palliative care services at Aga Khan, we've seen a dramatic improvement. There were certain outcome measures that we set up for ourselves, KPIs, and those KPIs were, number one, we wanted our patients to die at home, not in the hospital, but at home. And we've seen an increase in deaths at home. We've wanted a reduction of inpatient mortality in the hospital, and we've been able to achieve that by transitioning these patients to home. We've also decreased the length of stays in the hospital by transitioning patients to home care. And the rehospitalization, the 30-day rehospitalization rates have tremendously gone down since we developed these home-based palliative care services. Challenges that we encountered, again, not unique to us and AQU. I'm sure it's going to be very similar to what Dr. Harun's team is experiencing as well, is as you know, Karachi is not the safest of cities in terms of security. So we often have areas that are flagged by our security department. These are red zones. You cannot go over here. Even though we want to provide care over here, it's a security issue, and we're not able to do that because there's risk of harm, injury, or threats to our staff members. Then the other problem is transporting parenteral controlled substances. So it's already, when you're trying to prescribe opioids in the hospital, is like pulling teeth. Now imagine trying to provide parenteral opioids at home. It is a very, very difficult challenge because of the regulatory barriers that we encounter from the Ministry of Health, from the Ministry of Narcotics Control, from the Ministry of Health in Sindh. And then a lot of our patients, because they have changes in their conditions, so the family members will panic and they will ask or demand, we want the doctor or the nurse to immediately visit right now, in the middle of the night. And those are things that unfortunately we're not able to cater to. Our demand for the home-based palliative care services is actually through the roof. So we've got such high and tremendous demand that often we have to refuse services because we just don't have the manpower, the doctors or the nurses to actually deploy at home. Often we have to put them on a waiting list, or we just have to refuse service to them. Staff transportation is also very difficult, as you can imagine, picking up each staff member from their home, transporting them to the patient's home when you're living in Karachi, where all of the roads are broken down, where you've got water that is there since the rainfall that happened 2 months ago. And then you've got a logistic issue because transportation itself can take anywhere between 2.5 hours for the staff to reach the home. And then the staff attrition and retention, something that we've struggled with because you can imagine when we have patients in the hospital, we struggle with family members because we have joint family systems. So we've got a large family that's coming over here and asking questions about the patient. Now, put yourself in the shoes of the doctor or the nurse who's actually visiting at the home. And in the home, you're alone. And you've got all of these 20, 30, 40 family members that have encircled you, and you're caring for a dying patient. And all of those family members may not be on the same page. They may not have the same level of acceptance of the dying process. Many of them may still be in denial. And we've had instances where they actually locked the door, closed the door, and wouldn't let our healthcare provider safely go outside. So these are the things that actually lead to burnout, to caregiver burnout, to compassion fatigue. So we've lost a lot of good nurses, good doctors over the years, and having to recruit them in a field like palliative care, where there's not a lot of money and revenue to be generated, can be a difficult challenge. So with that, I'm going to conclude my talk. I'd be happy to take any questions in the Q&A. Thank you very much.
Thank you very much, Dr. Atif Fakar. Now I'm going to move to the next talk. It's also going to be on home palliative care service by Dr. Harun Hafiz. So I'm going to invite Dr. Harun Hafiz.
Okay. Well, we have to wait. I think they put Aisha Amreen's talk. I think I look like Aisha, so they actually had to confirm my name. Oh, you're not Aisha. So, right, I think most of what we wanted to discuss today has been covered by Atif and by Ian, especially the focus of care and what home-based care is all about. And I think if we are to talk about the future of palliative care, the model is going to change completely towards home-based care. I think palliative care is a specialty which probably over the next decades is going to be primarily a home-based specialty and a teleconsultation specialty than something which is actually to be delivered in the hospital or even standalone hospices. With that, say hi. यहाँ से नहीं चल रहा यहाँ से नीचे Okay, so we've already covered what the objective of home-based service essentially is, which, I think there should be no doubt is about taking care to the patient's home. If you just imagine what your average palliative care patient is like, most of them are bed-bound or wheelchair-bound at their best. Very few patients are mobile. Coming to the hospital in itself is a very tiring chore for them, going through the hassle of transport and everything, then waiting in hospital waiting areas, high rates of infection and everything. So when you take this service to their home, whilst it's an excellent thing for the patient, you also have to look at the logistics, some of practical aspects that Atif talked about, like the security of staff that are visiting there. So those are things that you have to cover. Like in our team, we have a rule that when they go inside the house, they actually call a dedicated number to let people know that they're going inside the house. And then if they've not called us back within 40 minutes to let us know what's happening, then we start calling the driver of the vehicle in which they've gone to go into the house. So these are practical issues that you're faced with. And then, like in every service, you also have to look at the cost of actually taking this care to somebody's doorstep in terms of the fuel, staffing, and all of those things. So what we've done is that we've started, although taking a leaf out of AKU's book, we've started on a sort of spoke and hub model as well. We've got the centers in Peshawar and Lahore, which are acting as the nucleus for our teams. We've got a 24-hour helpline, and 9 to 5, it is manned by our palliative care doctors. After hours, it is manned by the on-call staff. And during 9 to 5, we receive calls, and what we try is probably try and settle most of the calls we receive on the phone and most of those issues on the phone. So if you look at our call numbers, we'll receive calls in the hundreds, but very few will select to visit at home, which is not primarily because they didn't need a home visit, but at the moment we only have 3 physicians doing this, 2 based in Peshawar and 1 is based in Lahore. And every time a physician or the team goes out, a physician and a nurse goes out, and they take some basic medical equipment and drugs with them. The one thing that we do is when they are at the home, the doctor calls the on-call consultant. Between Peshawar and Lahore, we have 4 consultants, so they supervise this service by being available for the doctor who goes into the house. So they call and they let us know, they discuss the case, and then we give them whatever advice we need to give. And I feel that we've been recently, because it's all very recent, it's all started this year, our quality assurance department has started getting feedback or taking feedback from the patients who were visited. And one of the things that has been working well or commendation coming in for is the fact that the patients feel that the consultant has been part of the visit and the encounter. So that always helps. We are currently restricting the visits to a radius of about 20 kilometers from each hospital site. Although in Peshawar, this 20 kilometer has been drawn very carefully, because I think in 20 we reach the Afghan border as well or something like that. So usko thoda sa humne kam kar diya. But otherwise, it's the general rule is that at the moment it's very limited. Eventually, yes, this may happen that we've got collection centers all over the country. And if we are able to have, the network and the recruitment of professionals, we'll keep on increasing the access area that currently we can provide. But you can imagine that us being a tertiary care specialist cancer center receiving patients from all over the country, a radius of 20 kilometers is actually a very, very small thing to work with, but it is a start. Currently, we've had about 70 home visits in Lahore and about 27 home visits in Peshawar. And as you can see that those home visits have been tailored mostly around symptom management or around things that could be done at home, such as change of catheters, change of NG tubes, change of dressing, wound care, wound management, and things like that. If you look at the costing of it, I think an overall impact is in the benefit, because all of these patients would otherwise end up in your emergency. It would increase the footfall in your emergency. It would increase the doctor's time over here in the hospitals as well. And not always the doctors assessing them in the emergency would be well versed in palliative care. No disrespect to our emergency and acute medicine physicians, but palliative care does need a different mindset of doctors to be looking at things. And often when these people end up in the emergency, they end up having, before you even say hello in any emergency, and generally you end up having a full set of blood work and urine tests and whatnot. So you will see that bill of up to thousands has been raised in the investigation because they've just turned at the emergency foot too. And now if you look at the calls, you will see that it is a phenomenally high number of phone calls that has been received. And as I said, the endeavor always is to try and sort out most of the issues on the telephone rather than visiting them in person. And as an example, I think we have a few minutes, so I'm just going to discuss one case just to give you an idea of the sort of care that we end up providing. So this is a gentleman with end-stage melanoma, extensive metastasis to brain, lungs, bones, and liver, bed bound, waxing waning consciousness with reduced oral intake, pressure ulcers, and respiratory distress. And he had feeding going in through an NG. Now, for just 1 minute, imagine if you were the caregiver of such a patient, and just for 10 seconds, go through a list of things that you need to organize to bring a patient like this to the hospital, starting from booking an appointment with the palliative care physician, to arranging a car, to convincing a patient with all this going on with them. They will probably say, leave me alone. I'd rather be in pain and I'd rather be where I am than go through the pain of shifting from my bed to the stretcher, then to the ambulance, then being driven miles in the traffic to a hospital, then waiting around in a hospital corridor for hours to be seen by a physician who will probably end up not spending more than about 10 minutes, which is probably an exaggeration in a routine clinical encounter. If you imagine a clinical encounter, even in a multidisciplinary clinic like the palliative medicine clinic, you'll probably end up seeing a junior doctor, a nurse, physician. So your total time may be half an hour or 40 minutes. But your consultant would probably at most spend about 5 to 10 minutes going through the. So you've gone through this pain of hours of arranging all the logistics only to have a brief 5-minute conversation with the consultant. So therefore, if we just imagine in our mind, if we were to transport such a patient, then you can see the value of this home-based service, that what it would bring. And then again, you see, with these patients, once you visit them at home and go through things at home, they often express the wish themselves. As Atif before mentioned, how many of you would want to die in a hospital, how many of you would want to be in the comfort of home. Once that trust is built, once they know that we can access this service, there is a 24-hour helpline, somebody is available on the other end of the line to help us, they will be very, very keen to continue care at home. And in fact, sometimes if there's a patient who's been on our telemedicine clinic for ages, and I suggest that why not visit the hospital? We've not seen you for a long time. It's a blatant no, because they are quite happy. They're having their symptoms sorted, the occasional visit at home, and rest of the consultations are on the phone. So it reduces hospital visits. Another case similar to like this one, chondrosarcoma, lung metastasis, huge mass on the right leg, very limited mobility, increasing pain at the tumor site. Now, you could argue that, they need to come into hospital, they need to be seen and examined, but all of that can be done at the home. Again, just step back for a moment, close your eyes, and imagine if you were the caregiver of such a patient, in a country like Pakistan with limited ambulance services and everything, how difficult is it going to be, and how costly is it going to be to bring such a patient to hospital, not to mention the emotional and the psychological burden on the patient of coming in and seeing all of this. So with this, we'll end my talk. Thank you very much.
Right. So from the communication skills to taking palliative care to doorstep to what we are doing here in our country, in Karachi, in Lahore. So you might be thinking, why palliative care then? So I'm going to ask Dr. Aisha Amreen to talk why I chose palliative care.
Assalamu alaikum, everybody. So I'm Dr. Aisha Amreen. I'd like to start off by expressing my sincere gratitude to the organizers of this symposium for their kind invitation. As you know, palliative care is all about personalized care. So I'm glad that the organizers thought about including this topic, and it's an honor for me to be actually telling you about my personal journey as to why I chose palliative care. So from as early as I can remember, I always knew one thing, unlike Dr. Chris. I wanted to be a doctor. Very cliche, I know it is, but actually it's the truth. I never had a backup plan, so it was not maybe I'll be something else. For me, becoming a doctor was the ultimate goal. But what I didn't know at that time was what kind of doctor would I be? Growing up, my family and friends would always say that I had a gift for caring for others. Compassion came naturally to me, whether it was looking after a friend who wasn't feeling well or simply being there for somebody who needed a shoulder to lean on. That sense of care and empathy became my strength. And eventually, with time, I got drawn to the idea of healing, of making a difference in people's lives. So when the time came to choose a specialty for post-graduation, family medicine called to me. It catered to a wide range of patients, different ages, different presentations, different conditions, different backgrounds, different stories. I loved that it required a holistic approach, that you had to care for the whole person, not just their illness. Also, one of the things that attracted me to family medicine was the fact that the comfort in knowing that I wasn't just treating the symptoms, but helping someone live their life better, healthier. But as fulfilling as this was, I couldn't shake the feeling out there that there was something more that I could do. There was still another piece to the puzzle that I hadn't quite found yet. That's when life threw an unexpected twist my way. I moved to UK, Norwich, where my husband was pursuing his MRCGP. And by coincidence, I ended up living in a hospital accommodation, sharing a wall and a window with a hospice. I could see patients and families walking in, the weight of illness and loss heavy on their shoulders, day in and day out. But there was also something else: kindness, comfort, and yes, even peace. I couldn't help but wonder what it was about this place that made it different, and why was I drawn towards it? Curiosity got the better of me, and my husband also pushed me into doing my observership in that hospice. What I discovered there was remarkable. I discovered palliative care. Palliative care was more than just medicine. It was the very essence of compassion in action. It was about honoring a person's dignity at the most vulnerable time in their lives. It was about understanding that quality of life matters just as much, if not more, than quantity of life. The hospice wasn't just a place of endings. It was a place where people found closure, relief, and even joy in their final days. The people who were caring for them were not any healthcare professionals. I believe they were the chosen ones. I knew right then that this was my calling. The holistic approach I loved so much in family medicine translated seamlessly into palliative care, but with a sharper focus on the end of life care journey. It wasn't about curing, it was about caring. And in this distinction, I found my true purpose. Interestingly, in fact, I would say unfortunately, around the same time, my khala, which is my maternal aunt, succumbed to lung cancer in Pakistan and was cared for at home without the adequate end-of-life care support she deserved, which reinforced my desire to pursue this as a career and gain further education and training in it. It was through her experience I learned how important it was to have a dedicated doctor with whom you could do the level of conversations that such patients and families need. How important it is to be paid attention to when the disease becomes incurable, not to be abandoned. How important it was for them to know that there are doctors out there who can understand your suffering and respond to you accordingly. Basically, I realized how people need to be at the center of their healthcare decisions to make an exit in a dignified way, with their wishes being respected and their suffering minimized. Therefore, I decided to apply for a job in the same hospice. And so my palliative care journey began officially in Norwich and Priscilla Bacon Lodge. And since then, have never looked back. Learning from every patient and every family has both been incredibly difficult, yet profoundly rewarding. The more I worked in palliative care, the more I realized it wasn't just about easing physical pain. It was about addressing the emotional, social, and spiritual needs of the people in their most vulnerable of times. It was the deepest form of compassion that I wanted to pursue. Choosing palliative care was never part of my original plan, but looking back, I realized it was exactly where I was meant to be. Every experience, every patient, every moment of my journey, starting from my love for medicine and my passion for caring for others, led me here. My palliative care moment started in UK, but alhamdulillah, I'm glad that I managed to bring it back to my own people, and I'm thankful to Dr. Atif and Khan University for giving me the opportunity to serve my own people. However, practicing palliative care in Pakistan brings its own set of challenges, as you've seen Dr. Atif and Dr. Haroon have shared. One of the biggest hurdles is the lack of awareness, even in the medical community. Our medical professionals don't understand what palliative care is, often confusing it, as has been mentioned, as terminal care or for dying patients. There's also a significant shortage of healthcare professionals in this field, making it difficult to provide the specialized care that our patients need. Financial constraints loom large. Many families simply can't afford the holistic support that palliative care offers. Resham was just mentioning about the challenges in pediatric as well. On top of that, resources are limited. And healthcare systems often don't prioritize this essential field. But despite these obstacles, the need for palliative care is immense, as has been shared by Dr. Atif. And every day, we are reminded of how important this work is, especially in a country like ours, where comfort and dignity of patients is often overlooked. But working in a team at AKU, I'm reminded every day how, with perseverance and desire to serve, we can provide comfort and dignity to our population despite all odds. Institutions like the ones mentioned by Dr. Atif, like Shaukat Khanum, like our University, have taken their challenge in stride and delivering to ensure that end of life
I think it was, how many years ago was it we were here?
2019.
So in 2019, there was a little group of us that were teaching some amazing doctors and nurses. And I think just in such a short time, what you've achieved, and that the odds really are stacked so much against you. And I think it's a testament to really the community of healthcare professionals that you've got, that have got such a clear vision, and hearing that personal testament was very, very moving. So thank you all very much indeed. I hope it inspires those who aren't yet particularly involved in palliative care, perhaps to reach out and join in. And to the rest of you, thank you so much for such a wonderful session.
Thank you.
And yes, and to thank Ian. It's lovely to see you, Ian, virtually.
Okay. Thank you very much. Thanks. Thank you all for joining us. Thank you.